Now let's study pneumonia. Pneumonia is an infection of the lung parenchyma. As we know, lung can be divided into parenchyma and interstitium. In parenchyma, this involves alveoli and the capillaries. In interstitium we have the collagen and the connective tissues. And pneumonia is basically infection of the lung parenchyma. And why pneumonia occurs? The cause for pneumonia is when, as we know, we have the protective mechanism or defense mechanism in the lung to protect against bacteria and virus. When these mechanisms fail to clear the bacteria or virus, we get pneumonia. And there are several defense mechanisms like coughing and mucociliary mechanism, because as we know, airways are lined by pseudostratified ciliated columnar epithelial cells, and we also have macrophages which are the residents in the alveoli, and we also have the IgA that is secreted by the mucous lining of the airway. And if these protective mechanisms are disturbed or altered, we develop infection of the lung parenchyma, that is pneumonia. And there are several types. We will discuss these types in detail. Now let's see the clinical features of pneumonia. Fevers and chills are common due to cytokines, and cough with yellow-green sputum. Yellow-green because due to the presence of bacteria and the exudate. Rusty sputum due to presence of RBCs. Tachypnea means rapid increase in breathing, and pleuritic chest pain because, as we know, there will be several inflammatory mediators released, and especially bradykinin and PGE2 will sensitize the nerves of the pleura. This causes pleuritic chest pain, that is pain during inspiration. And we can also see the decreased breath sounds and dullness to percussion. As we know, alveoli will be filled with exudate in these conditions, so there will be dullness to percussion. Normally there will be hyperresonance or resonance in the lung region, but due to filling of the exudate there will be dullness to percussion. And obviously there will be increase in white blood cell, that is leukocyte count. Now let's see lobar pneumonia in detail. Lobar pneumonia is mainly caused by strep pneumonia. This is the major or most common organism, and Legionella and Klebsiella can also cause lobar pneumonia. Here in lobar pneumonia, there will be intra-alveolar exudate, that is exudate within the alveoli, and this leads to consolidation. And here lobar pneumonia can involve the entire lobe or the whole lung. We will see the figure. As we can see in this figure, entire lobe of the lung is involved, and these are the airways. These are the airways but filled with neutrophils and other leukocytes, and involvement of one lobe or entire lung is common in lobar pneumonia. As we can see in this figure also, the entire lobe is involved. And let's see the pathophysiology. As we already discussed, due to impairment or dysfunction of these protective mechanisms like cough reflex, mucociliary mechanism, or macrophages and IgA antibodies, due to these defense decrease or destruction of these protective mechanism, there will be infection by the bacteria or virus. This is the alveoli and the surrounding capillary. When bacteria invades the alveoli, this releases endotoxins, and this endotoxin damages the alveolar wall, and there will be release of leukotriene B4. As you know, normally leukotrienes and prostaglandins will be released by the phospholipid bilayer. Even during destruction of the alveolar wall, there will be release of leukotriene B4 and other leukotrienes like leukotriene D4, C4 and E4. This leukotriene B4 is important because it is a chemotactic factor which attract the other inflammatory mediators like neutrophils and other leukocytes. And LT-D4, that is leukotriene D4, C4 and E4 are important because this increases the vascular permeability. Hence, this causes increase in the exudate, and surrounding the alveoli there will be many mast cells, and these mast cells will release the histamines, and this causes vasodilation and increase the permeability. And this leukotriene D4, C4 and E4 are important because this causes bronchospasm, and this also affects the breathing mechanism, that is, this causes shortness of breath. And macrophages release the cytokines like interleukin 1 and TNF alpha. This causes pyrexia, and interleukin 8 will also be released. Let's see the history of lobar pneumonia. There are some stages in lobar pneumonia, include congestion stage, red hepatization stage, grey hepatization stage and the resolution stage. Normally, as we can see here, this is the alveoli and this is the surrounding capillary. And in the alveoli, as we know, there will be resident macrophages, and within the capillary there will be WBCs, leukocytes. During congestion stage, this is during between 24 hours, there will be red, purple or partial consolidation of the parenchyma. This is due to exudate. When bacteria enter, there will be release of endotoxin, and this causes release of leukotrienes and prostaglandins. When this happens, there will be exudate. The first stage, that is during congestion stage, we only find the exudate with bacteria. Exudate because due to increase in the vascular permeability and vasodilation. This is called congestion stage. Next we have red hepatization stage. This is called red hepatization because the lung will look like a liver, because this occurs around 3 to 4 days. Here a red brown consolidation because exudate with fibrin bacteria. There will be RBCs, WBCs. As we discussed pathophysiology, there will be release of or entering of other WBCs and leukocytes to the site of infection from the surrounding capillary. Hence, during red hepatization, there will be red blood cells and WBCs and the exudate with fibrin. And even the red hepatization stage is reversible. Next we have grey hepatization. This occurs around 3 to 5 days. Here there will be grey color, so this is called grey hepatization because RBCs will be dying, that is due to breakdown of the RBCs, and exudate full of WBCs and fibrin. Here grey hepatization because RBCs will be dying, that is breaking down of the RBCs, and other bacteria will also be eaten up by the macrophages and other mechanisms. And next, last stage is resolution stage. This occurs around 8 days after a week, and here enzymatic digestion of exudate by macrophages. As we know, after infection there will be resolution by scarring or other type of enzymatic digestion. Here type 2 pneumocytes are important for the formation of normal lung because these are the stem cells which lead to formation of normal alveoli. Hence, congestion stage occurs in 24 hours, red hepatization stage occurs within 3 to 4 days, grey hepatization occurs in 5 to 7 days, around 8th day there will be resolution. The main mediator for next we have bronchopneumonia. Here acute inflammatory infiltrates will be in bronchioles and it will be spreading into adjacent alveoli. Here we see the patchy distributions involving the more than one lobe. Here the causative organisms include staph pneumonia and staph aureus, H. influenza and Klebsiella. We will see the picture. As we can see here, this is the patchy infiltrates that involves the pneumonia, and this is the X-ray. As we can see here, it can involve more than one lobe or entire lung, but it is patchy. It looks like a patchy because it involves the bronchioles and the adjacent alveoli. And some of the important points to be remembered is staph aureus causes the secondary pneumonia because it is superimposed on viral upper respiratory tract infection. If a patient has viral upper respiratory tract infection, then they will also develop secondary pneumonia because of staph aureus, and this is also complicated by abscess and emphysema. Next we have H. influenza. This is also due to secondary pneumonia, that is it can cause infection in COPD patients. So this is called secondary pneumonia. And we have Moraxella catarrhalis. This causes community acquired pneumonia and this also superimposed on COPD patients. Next we have Legionella pneumonia. This also causes community acquired pneumonia and it is superimposed on COPD patients, and this type of organism mainly infect the immunocompromised people, and this Legionella is spread through the water source and it can be stained or seen by silver stain. Next organism we have is Pneumonia aeruginosa, and this causes pneumonia in cystic fibrosis patient. Next we have interstitial pneumonia. This is also called atypical pneumonia because this does not directly involve the alveoli, but it involves the interstitium and then that disturbs the alveoli, walls of the alveoli. Here we see the diffuse patchy inflammation localized to interstitial areas at alveolar walls. On chest X-ray we see the bilateral multifocal opacities, and it is also called walking pneumonia because patient does not have symptoms but they can have mild symptoms like upper respiratory tract infection like cough, minimal sputum and fever. And there are causes and we will discuss these causes. As we can see here, this is the airway and that is alveoli, and this is the alveolar wall, and here we see the inflammation in the interstitium but no inflammation in the alveoli. Chest X-ray we see the inflammatory diffuse patchy inflammation which is not localized, and this involves the entire lobe, that is interstitium will be involved, so we cannot see the localized or patchy infiltrate, but here we see the diffuse interstitium infiltrate. And the causes include Mycoplasma pneumonia. This mainly occurs in young adults who live in closed spaces like college dorms and military recruits. And this Mycoplasma pneumonia causes autoimmune hemolytic anemia, that is cold agglutination, and it also causes erythema multiforme. Next organism we have is Chlamydia pneumonia. After Mycoplasma pneumonia in young adults, second most common organism to cause interstitial pneumonia is Chlamydia pneumonia. Next we have RSV. This causes in infants, pneumonia in infants. CMV, this causes pneumonia in post-transplant immunosuppressive therapy. And next we have influenza. This is a virus This mainly causes in elderly people and immunocompromised people. And after infection by this influenza virus, there will be superimposed infection by the SRS and H flu, that is Haemophilus influenza. Next we have Coxiella burnetii. This mainly occurs in farmers and bird fanciers, and this causes Q fever. Next we have aspiration pneumonia. Here the aspiration of any oropharyngeal or gastric contents leads to pulmonary infection. Aspiration can be seen in alcoholics, comatose patients, altered mental status patients due to decreased cough reflex and the glottis closure, and who have dysphagia, neurological disorders like stroke, and on people who are on invasive tubes like nasogastric tubes. These people can develop a aspiration pneumonia, and the main bacteria which causes the aspiration pneumonia is anaerobic bacteria like bacteroides, fusobacterium and peptococcus. Here the presentation will be after several days of aspiration, and this most commonly cause the right lower lobe if the patient is sitting, and right upper lobe if lying down. This can be easily identified. While sitting, this can occur. Aspiration pneumonia is seen on the right lower lobe, and while lying down it can be seen on right upper lobe, and this can progress to lung abscess. This is the most major complication of the aspiration pneumonia. And we also have aspiration pneumonitis. This is due to ingestion of the or aspiration of the gastric acid, and this causes inflammation in the lung or lobes. This mainly infiltrates the lower lobes, and the treatment is supportive, and this mainly occurs after the hours of aspiration of gastric acids that mediates the inflammation. Next we have cytogenic organizing pneumonia. Here there will be no infectious organism found on the sputum or blood cultures. Here this type of pneumonia responds well to glucocorticoids but not the antibiotics. Because there are no organisms that causes this type of condition, this is also called bronchiolitis obliterans organizing pneumonia, that is BOOP. Here there will be no infectious agents. This is called non-infectious pneumonia. There will be inflammation of bronchioles and surrounding structure, but the causative organism will not be there and cannot be found on sputum and blood cultures. This is the main important point to be remembered is BOOP, that is bronchiolitis obliterans organizing pneumonia.